Welcome to Experts on Call, featuring one of our most popular experts here at CFUN 1410 AM. I'm your host, Peter Shad, and his impressive resume includes heading up the Faculty of Child Psychology at the University of Ottawa before lecturing in psychiatry at Harvard for 7 years. Now he's in Vancouver and become one of the leaders in the field of biofeedback and neurotherapy, which is the medical science of adjusting brain waves. We're very lucky to have him here in Vancouver, taking your questions today and talking a little bit about traumatic brain injury and stroke. Welcome, Dr. Swingle, and happy Easter.
Happy Easter to you.
So many things to talk about. Included in this next hour, you're going to hear how a woman recovering from stroke improved after only 10 sessions of neurotherapy. And what do the majority of death row inmates all have in common with regards to their brain? You'll be very interested to hear both. Let's talk a little bit about what neurotherapy is first, because every time I mention it to somebody, they give you that blank, glazed-over look, and they think electrodes, brain. Isn't that what they did in One Flew Over the Cuckoo's Nest? Something totally different.
Absolutely, totally different. And hopefully my book will change all of that when it comes out later this year, published by Rutgers University Press. It's designed to introduce this and get it up on the radar screen. Neurotherapy is not new. It's been around for at least 40 years. Its initial use was in the treatment of drug-resistant epilepsy. Because of our limited technological capabilities at the time, 40 years ago, the computer technology that we had, it was much too costly to have as a general clinical treatment procedure. But as the technology improved, then we were able to introduce it into primary care practice. What neurotherapy does, quite simply, is measure brain activity, the electrical activity coming from the brain, and look for areas of inefficiency. When we find an area of inefficiency, then we know there are symptoms associated with that. That's why I don't ask people why they come to see me. I look for the areas of inefficiency in the brain, and I tell them why they're sitting there. Once we isolate those areas of inefficiency, the way they're corrected is referred to as neurotherapy, and there are 3 general classes of treatment in neurotherapy. The most important one is neurofeedback. Basically, we set it up so that when the brain is doing what we want it to do, the person will hear a tone or see something move on the computer screen. If it's a child, we set it up so that they can play a game with only their brain. They can make items move around on the screen, Pac-Man, fly spacecraft, and so forth. What that does is it normalizes brain function. And as the brain areas become normalized, then the symptoms associated with the inefficiencies drop out. It's that simple. The other aspect of what we do is peak or optimal performance training. And as you know, the team that won the World Cup, the Italian team, every man on the team did neurotherapy. It was considered their secret weapon.
They also had some element of brain damage from hitting all those soccer balls, so maybe that helped fix it.
Maybe.
We'll talk about the impact of a soccer ball to the head a little bit later on. Our subject is traumatic brain injury and stroke, but we'll happily take calls on any brain-related functions. If you'd like to ask a question to Dr. Swingle, he is live here today, and he loves taking your calls and hopefully helping you. One thing that you've done over the course of being on this program is offer people hope when they felt as though there was nothing they could do anymore. The medication wasn't helping them as much or didn't help them at all and just made them feel terrible. Your book, by the way, is also called It's All in Your Head, if I'm not mistaken. Is that the working title?
No, Rutgers University Press didn't think that was elegant enough.
What?
I think they're going to call it Biofeedback for the Brain. And the other one, the second volume, is written for primary care practitioners. Rutgers is going to publish that as well.
When people come in to see you and they talk about their issues and you talk about hooking them up, what is the first thing that they have to do when they visit you for the first time?
Basically, I ask them, have they had a previous head injury? Have they ever had a seizure? And are they on any medications at the time? Then I put a wire in each ear and one on top of their head, and I move that wire around to different brain locations. They won't feel anything because it's measurement only. I ask them to open their, close their eyes at various times. I ask them to read something. For a very young child, I might ask them to count. And I test a few harmonics. I play a sound because some of the treatments that we use make use of harmonics, and I want to pre-test it to make sure that it works. That's what's so effective about this procedure. Before we prescribe anything, we test it to make sure it works, so we know exactly what it's going to do to the brain. There's none of this, take 2 of these for a week and then come back and see if something happened.
And, of course, this type of therapy is regulated in the U.S. You're registered, certified. You have all the other degrees and all the other psychology, psychiatry-related skills that you should have when you're performing neurotherapy.
Absolutely. I'm a great believer that the only neurotherapist you should ever go to is one who's licensed to practice some other discipline, be it medicine, psychiatry, psychology, clinical social work. That person brings other skills to the table because neurotherapy is not a standalone discipline. Depression is a good example of that. Once we correct the neurological condition associated with that, you've got some mental attitudes and mental habits that may be sustaining the depressed mood state. You need a little bit of help to push yourself out of that. The one-size-fits-all folks that are popping up around because it's not regulated in Canada simply don't bring those skills to the table.
And once you've gone through neurotherapy treatment, and once it's fixed for good.
That's right. The only exception to that are age-related declines. For age-related declines, we have folks come in 2 or 3 times a year because if we can keep these specific waveforms in normative range, it absolutely prevents dementias, and it delays Alzheimer's, and it correlates very well with good immune functioning.
That's Dr. Paul Swingle. This is It's All in Your Head on CFUN 1410 AM, Experts on Call. There used to be this feeling that if you'd had a stroke after 18 months, that was it. There was no point of recovery. We're going to prove that that's not the case in just a few moments. But let's take a phone call from Evelyn this morning who has a question related to stroke. Hello, Evelyn. Thanks for listening. You're on CFUN 1410 AM with Dr. Paul Swingle.
Hi there. I just wanted to ask a question. My father had a TIA in November last year, but it was considered now a mini stroke because he has the repercussions of a stroke left on his left side.
Yes.
But he's doing very well. He's walking fine, except he feels a real tightness throughout his left leg and arm.
Yes.
And he doesn't really know why. And why is it? He can walk fine. He can talk fine. Everything is great. His memory is perfect. He just has this feeling of tightness that doesn't go away, no matter how much physiotherapy he takes and does. It's just very irritating to him. He just doesn't know what to do.
Yes, what he had was referred to as a ischemic event, which is a reduction of oxygen to a particular area of the brain. And what your father had was a motor stroke. One of the legacies of that is a loss of strength in one side of the body, numbness, tightness, exactly what Evelyn has been describing. There are a lot of things that can be done for that. Basically, we look for the area that's been affected and activate that particular area so that you get recruitment of function. So there's a lot that can be done for that. Incidentally, that's a good point that Evelyn brought up. A lot of individuals have stroke symptoms but have never been diagnosed with a stroke. And those symptoms are associated with numbness, loss of feeling, feelings of tightness, that kind of thing in one side of the body. It's usually transitory, but there are a lot of these issues associated with what you might consider to be mini stroke.
Evelyn, how old's your dad?
80.
80 years old.
Yes.
Well, best of luck, and I'll give you the number of the clinic here, because this is the kind of thing that Dr. Swingle and Associates deals with. Telephone number is 608-0444. You're listening to Dr. Paul Swingle. It's All in Your Head, and in just a moment, you're going to hear the dramatic difference before and after 10 sessions of neurotherapy from a former stroke victim and a patient of Dr. Swingle's. And later on, you'll find out, what do death row inmates all have in common with regards to their brain? Swingleandassociates.com is the website, and you'll find all sorts of resources, including all the various conditions that are treatable through neurotherapy. You'll see some testimonials. You can hear our radio show if you like. I guess we shouldn't just assume that everybody knows what a stroke is. What exactly is happening to the brain when someone suffers a stroke?
Basically, it's a deprivation of blood and or oxygen to specific areas of the brain. There are many causes of that, aneurysms and so forth and so on. And the symptoms are associated with where the stroke occurs. A lot of them are what are referred to as motor strokes, and that accounts for 15 to 20% of stroke clients that are seen. And basically that's where you lose strength, feeling, control of one area of the body, usually one half of the body. That also can be a variant in terms of where the stroke occurred. You lose control of the arm, the leg, facial muscles, and so forth. Now, usually in a motor stroke, you don't lose cognitive functioning, no problems with memory and so forth. As the stroke moves into different areas, then you can get cognitive impairments, individuals having problem with memory, recognizing people, things of that nature. But basically, the direct answer to the question is it's a deprivation of oxygen or blood to a particular area of the brain.
It used to be believed that after a stroke, 18 months go by, and that's as much improvement as you can get, and then that's how people they'd be stuck no matter what level of cognitive motor functions they had. That would be it.
Yes. What we were taught in medical and graduate school when I went to school is just wrong, period. There's been a lot of evidence to indicate that the brain is really plastic. Dr. Ledoux at NYU's written a couple of books on brain plasticity. Bruce Lipton, the biologist, likewise has written many books showing that the brain can recover function. That is, areas of the brain not primarily responsible for that activity can assume that responsibility. And we have a lot of MRI studies that show recruitment of other areas of the brain. Now, there are a lot of different therapies that you use. The first is neurotherapy to arouse the brain and try to establish new brain networks. Then there are other therapies that we do in conjunction with it. Sometimes we work with other professionals. For example, restraint therapy is very effective. If a person has lost control of, let's say, their right arm and hand, what we do is we do some neurotherapy on the left side of the brain, that motor area associated with the right hand, and get those areas aroused and activated. And then we work with somebody in terms of restraining the right arm for a period of time during the day so that the person has to do whatever activity they do with their affected hand, their left hand. In the first instance, that's very frustrating, as you can imagine, and there's a strong desire to use the unaffected hand. But there's a lot of work that has been done in a number of major universities indicating how successful this can be. We usually use tear-off bandages, so if you fall, you can pull your hand free. Restraint procedures in combination with neurotherapy can be extraordinarily effective. This can happen 10 years after the stroke. The notion that after 18 months, game over, you might make minor improvements with physiotherapy, range of motion, exercises, that sort of thing. That's just wrong, period. And the tape will demonstrate that to the audience. This is a woman who, I think the best description of this is a mini stroke following brain surgery. She had a number of complications, one of which was impaired speech. These are two clips that come from my answering machine when I was at Harvard Medical School. And the first one is she calls in to try to arrange for an appointment. She's only had an intake assessment. She hasn't had a treatment yet. So the listening audience can hear what her voice sounds like. The second one is only 10 or 11 sessions later. And if the listening audience just focuses on the quality of this speech, you'll get an idea of what can happen in terms of neurotherapy for stroke, brain injury, quite a long time after the actual event.
All right, so let's hear this. This is a woman who 10 years back had suffered a stroke following some surgery. Let's play the first phone call after the initial intake from this woman who wanted to schedule an appointment. Listen very carefully to her voice.
Dr. Swingle, I'm not going to be able to make a 9 o'clock appointment. We're still digging out up here in Scranton. I'll call you back and make an appointment for next week. Bye.
Okay, so that's the first one. Now, this is 10 sessions later, the very same woman.
Dr. Swingle, this is Caroline. I'm calling to make an appointment for next week, Thursday at 11 o'clock. If that's not good, could you give me a call back and let me know which would be a good time? Thank you.
She wasn't dragging her words out as much, nor was she leaving as big gaps between her words. Interesting.
Whenever we treat traumatic brain injury, stroke, that sort of thing, one of the first things that starts to improve is speech. The other is emotion. And that's very rewarding for the client because often they've been going through a long period of time in which their improvements have been very minor because they are so far beyond the cerebral accident. And then when something dramatic happens, like some sort of improvement of function, be it motor or voice or emotion, then it gives them a lot of optimism.
Obviously gives you a lot of optimism, too, which is one of the reasons why you're here, spreading the gospel of neurotherapy. And again, that was 10 sessions only. Our whole focus of the program here is to dispel the notion that whether you had a stroke 18 months ago, 6 months ago, 10 years ago, there is still some improvement to be gained from neurotherapy and biofeedback. Let's take a quick phone call, and we've got Bob on the line. Bob, thanks for listening. You're on with Dr. Paul Swingle on CFUN 1410 AM.
I have a question. I had a surgical procedure about 8 years ago, which left me with the symptoms of stroke, and the MRI scans showed no evidence of stroke. The surgeon said that there was an oxygen deficiency, and I'm wondering if the neurotherapy can treat oxygen deficiency.
Yes, a lot of stroke symptoms are associated with oxygen insufficiency. I don't think your surgeon means that you presently have oxygen insufficiency unless you have something like sleep apnea. If you have sleep apnea, then there is an oxygen issue, and it is one of the apparent indicators of elevated risk for stroke. One of the things that we do is treat sleep apnea because what that does is affect blood pressure, and we know that blood pressure is a risk for stroke. It's that kind of sequence. To answer Bob's question, if there is a oxygen insufficiency that has caused frontal damage, what we can do is treat the frontal lobes, look around for areas of damage, which is usually excessive slow-frequency activity, and arouse those areas. What I mean by that is normalize the functioning of those regions in the brain. If there is an ongoing oxygen issue, then what we have a look at is peak flow to make sure that the oxygen levels are adequate, and we can test the oxygen levels in the blood. Sleep apnea may be another issue. There are a lot of possibilities here, but my guess from what he's indicated is that he experienced an ischemic stroke associated with the surgery. It's not unusual, by the way, not to see anything on an MRI because it's looking at structure, and what we look at is function. For example, in seizure disorders, there are certain forms of epilepsy that only about 25% of them are picked up with MRIs, whereas functionally we can see that there's a functional deficiency.
Let's take some more phone calls here and welcome Patricia. Patricia, thanks for waiting. You're on with Dr. Paul Swingle on CFUN 1410 AM.
Hello. I just want to say I went to Dr. Swingle's office. I have fibromyalgia, and when I first saw Dr. Swingle, he said that maybe he could help me and that it might take a long time. I went for about 25 sessions, and I've had a remarkable change in my health. I have much more energy. I don't have headaches that I used to have, and it was so worth it.
Wow. Hey, Patricia, I can't thank you enough for calling. Fibromyalgia, another one of those we thought 10 years ago a phantom disease. Nobody knew what it was. An unsolicited testimonial there from Patricia. Thank you very much for calling.
Yeah, thanks, Patricia, for sharing that. Fibromyalgia, by the way, ties right into the whole notion of traumatic brain injury because what we usually find in fibromyalgia is traumatic brain injury and some other factor like severe emotional stress or viral infection. The title of this radio broadcast, It's All in Your Head, is largely stimulated by the reports we get from people like Patricia, who have gone through goodness knows how many physicians and psychologists, and the message they get from these people is, it's all in your head. And I like to say to these folks, of course, where else would it be? And you correct it at its origin.
Do you ever use your brain as like a giant computer analogy, and if one little circuit isn't working, then something breaks down in your system?
I don't understand computers.
But they're very integral in your office, that's for sure. We continue with our subject, traumatic brain injury and stroke. You're listening to Dr. Paul Swingle and Associates. The website is swingleandassociates.com. Earlier on, I had talked about inmates on death row and a very, very interesting factor that linked them all together. What is it?
Frontal brain damage. There are two studies that I have in my book. There are a lot of other ones, too, but one was done by Dr. Jim Evans, and he looked at brain maps of death row inmates, and another one was done by Ricardo Weinstein out in California, who likewise did brain maps electroencephalographs of death row inmates. In one case, every one of them had frontal lobe damage, primarily on the right side. In the other one, I think it was 19 out of 20 had frontal damage. The frontal lobes, where all of the executive functions reside for things like planning, organizing, sequencing, all the cognitive functioning, but also all of the emotional and impulse and anger control functions. So individuals who have damage to that side of the brain are much less able to exercise control over their anger and rage and impulses. It's interesting that we treat a lot of children with conduct disorders, defiance disorders, and that sort of thing. Inevitably, the right frontal cortex is showing some abnormalities. Neurotherapy can correct these things by normalizing brain function, getting the frontal lobes into balance. But it's interesting, if you look at the consequences of mild traumatic brain injury, a lot of them mimic the diagnosis and consequences or characteristics of ADD, learning disorders, conduct disorders, and so forth. And there's a whole list of common consequences of mild traumatic brain injury: family breakdown, chronic pain, distractibility, irritability, impulsivity, difficulty dealing with change, poor concentration, etc. A lot of them. Lack of stamina.
Now, when you talk about the frontal lobes of the brain and the damage they sustain, when we're talking about inmates, is it true that that part of the brain also regulates moral judgment?
Yes. Interesting that you mentioned that. There's an article that just came out on brain damage affecting moral judgment. Individuals are just not capable of efficiently making moral judgments,
which might lead them to death row.
Do all kinds of things.
We all, at some point in our lives, have some element of brain damage, whether it's from being infants to teenagers or whatever. You're not saying that just because you have damage in the front of your brain, you're going to wind up in prison, but an interesting link nonetheless.
It's interesting. If you look at the number of individuals in prison, incarcerated offenders, the number that have ADD and ADHD, for example, is dramatically greater than the general population. Now, there's a link. An individual has ADD, for example, they're unsuccessful in school, they feel stupid, their self-esteem is affected, they get into alcoholism, and that leads down the road to criminal behavior. A brain injury, if the conditions are right, that can lead to impulse control problems. If the individual's in an environment in which that's an issue, he may get involved in something that leads to the harm or death of somebody. The answer to your question is there are other elements besides brain injury that give rise to these kinds of consequences, but brain injury is the common thread that's running through all of these things.
Now let's talk a little bit, we're on the subject of traumatic brain injury and stroke. And kids, just the fact that they're kids, and they're bouncing around and falling off things and jumping off things they probably shouldn't. I guess the older that they get, the more protected they are against those kind of incidents happening. How many of us do have little bumps and bruises we didn't even notice but have affected the brain?
Everybody. We've all banged our heads as kids. No matter how you're hit in the head, the frontal lobes are always implicated because of the way the brain sits in the cranial vault. One of the evidences of that kind of notion that everybody's carrying around a little bit is that very often you'll have a person come in with clear evidence of the characteristics associated with traumatic brain injury, and they report they've only had a very minor kind of accident. Their physicians are puzzled by it, and they're puzzled by it because they had this dramatic response. It looks as though these kinds of things are cumulative. You have a few brain injuries, and then one little thing puts you over the edge.
Dr. Paul Swingle in studio taking your calls and answering your questions. The website address is swingleandassociates.com, where you can get all the contact information you need. Hi, Arden, are you there?
Hi, yes, I am.
All right.
Thank you so much. I am inquiring about a person that had a brain aneurysm, and she's been in the hospital for over 2 years, and she does respond like smiles and things like that, but is there any hope?
Oh, yes, absolutely.
There is.
The brain is very plastic. It's hard to know how much recovery we can get. Sometimes we get a little bit, sometimes we get quite dramatic changes. Let me give you an example. We used to think that individuals in coma would not respond to something like neurotherapy, for example. We have compelling evidence now that individuals in coma can respond to neurotherapy. There's a woman in California who really pioneered this work. Her name is Margaret Ayers. And she has at least 75 examples of individuals who are brought out of coma with neurotherapy. Basically, you have to hold the eyes open and use the feedback lights. Nurses who work with coma patients have known this for a long time. If we would only listen to people who have the experience, they will tell you when you're in the presence of somebody with a coma, you don't speak negatively, you speak positively. You talk about the person's interest, you sing songs that the person likes and remembers, and so forth. And there's some nice evidence of that. People that have been hooked up to biofeedback instruments like heart rate monitors, heart rate accelerates when a loved one walks into the parking lot. These folks are responsive, and neurotherapy is a method for accessing that level of plasticity in the brain. So when we have these very severe brain injuries, it's hard to know how much progress we can make. We've got a lot of different methods of neurotherapy that we use in these kinds of conditions, and we really don't know how far we're going to be able to go until we hit the brick wall of no more progress.
You know, it's unfortunate because after this long of time, everybody sort of gives up. We have tried to bring her out to where she used to live and show familiar places and things like that. And she does smile, but is that the right steps? Continue doing that?
Oh, absolutely. One of the problems with giving up is the person no longer has a variety of stimulation. That kind of effect exacerbates the problem.
Let me give you a telephone number there, Arden. It's 604-608-0444, 608-0444 for Swingle and Associates, the website address, swingleandassociates.com, where you can get all the contact information. Is neurotherapy equipment portable? Can you actually take this gear around to help people who are, either incapacitated or, in hospital?
Yes. Mm-hmm.
All right.
Sure.
And we also want to get into what it is that you're giving your children that actually has twice the impact of cocaine in their system. Today we're talking specifically about traumatic brain injury and stroke, an area where a lot of people have felt that, once a stroke has happened or a bad car accident or a severe hit to the head, after 18 months, that was it, no more progress, and that was where you were stuck in life. And that just isn't the case anymore, as we've given you example after an example. And we're going to play that clip again of the woman who called your office 10 years after suffering a stroke following some surgery, and then 10 sessions later, and you'll hear the dramatic difference in her voice. So, what are we giving our children that has twice the potency of cocaine?
Well, one of the things that we're starting to find when we're treating kids with ADD is there's a deficiency of a particular brain wave in the frontal part of the brain. And that's been increasing over time as we see these kids. What it looks like is the kind of frontal lobe damage that's associated with methamphetamine abuse. And it turns out that Ritalin, methylphenidate, looks and acts very much like cocaine, except it lasts longer and inhibits dopamine reuptake more deeply. Ritalin, about 70% versus 50% for cocaine. If you look at the drug doses, most kids take at least 40 milligrams a day. It's not uncommon to do 80, and we've seen it as high as 110 milligrams a day. If you take the middle one, 80 milligrams, times 30 days, that's 240 milligrams a month, which is about half the dose seen in an adult cocaine user. There's a lot of research on the effect of cocaine, methamphetamine, and so forth on brain damage. So, brain damage, brain injury can come from a lot of different sources. It can come from head injury. It can come from emotional trauma. I have an article here on the brain shrinkage associated with infants and children exposed to traumatic stress. The brain is actually structurally affected by that experience. It can occur associated with drugs that are used. It can occur, of course, with stroke. It can occur with head injury. All of these conditions give rise to symptoms, and they are all treatable to some extent with neurotherapy, combined with the other therapies that we use.
This is one of the biggest reasons why you're here every month, why you've written your book. before somebody tells you that your child has ADD and they need to be put on some kind of medication, you might want to consider neurotherapy, which doesn't involve any medication. The cost difference, I don't know how much it costs for those kind of medications, but your treatments run about, what, $90 to $100 per session?
That's correct.
It'd be interesting to compare that one day. But, I mean, long term, you're talking about Ritalin, that's frightening. And you've said it enough times on this show, kids being boisterous is what kids do.
That's right, yes. And we're using these drugs for conduct and behavioral control, which is an outrage.
Let's just go back to something we ran a little bit earlier. This is a patient of Dr. Swingle's from your years in Harvard.
That's right.
And it had been 10 years since she'd suffered a stroke after some surgery. She wanted to make an appointment. So after you saw her and you went through the initial intake, she left this message on Dr. Swingle's answering machine. Listen very carefully to her speech.
Dr. Swingle, I'm not going to be able to make a 9 o'clock appointment. We're still digging out up here in Scranton. I'll call you back and make appointments for next week. Bye.
Okay, so that's and then this is 10 sessions later. Listen to the difference in her speech.
Dr. Swingle, this is Caroline. I'm calling to make an appointment for next week, Thursday at 11 o'clock. If that's not good, could you give me a call back and let me know which would be a good time? Thank you.
What a dramatic example of what you do.
Telephone answering machine research.
Yeah. In case you've just joined us and you hear that, you're wondering, well, what on earth can cause a woman to sound so markedly more expressive, energetic, not so much slurring of her words, and not so many gaps between her words? What is this neurotherapy? What are you doing?
Yeah, there's a brilliance to her voice the second time. Basically, we look at the electrical activity in the brain, and we look for areas of inefficiency in the way the brain's functioning. Symptoms are associated with abnormalities in brain functioning, and the way we remove the symptom is by normalizing the brain function. We do that in a number of different ways, but one of the fundamental ways is brainwave biofeedback. We set it up so that if it's a child, for example, a child plays a video game with their brain. They can make electric trains move on a track only with their brain, or they can get icons to move on a computer monitor, play Pac-Man with their brain. And that normalizes brain function. And once it's fixed, it's fixed. We talked earlier about Ritalin. Somebody calculated that the break-even point with common ADD is about 1.5 years of Ritalin use.
Wow. What are brain drivers?
Those are developed in my clinic over the last 10 years or so. These are technology we use very often for people who can't do volitional neurofeedback, people with a stroke, head injury, autistic kids. We measure the brain activity. Based on that measurement, we stimulate with light, sound, microamperage stimulation, EMF fields, and so forth to nudge the brain into more normative functioning. Once it gets into more normative ranges, then they become capable of doing volitional feedback. An autistic child might start all with brain driving, no volition at all, that is, no voluntary procedures, and then gradually move to more volitional neurofeedback as they progress.
You have a lot of kids that come to your clinic.
Huge number, yes.
And you have a lot of out-of-town people that come to your clinic.
People fly in from all over the world, yes.
You're busy a lot, which is, I guess, good. And you hired a colleague now to help take some of the load, which has allowed you to see more patients, I'm guessing.
Yes, I hired a very experienced man from Reno. He brings a lot of skills in terms of some of the adjunctive therapies that we use in addition to neurofeedback for processing some of the emotional content that is elicited when we do neurotherapy.
Here's how you get a hold of Dr. Swingle. The telephone number is 608-0444, 608-0444. And the next time you're back, in a month's time, Dr. Swingle, you will talk about
the treatment of severe emotional conditions.
Or as you like to call it,
cancer of the mind.